Hello, I'm Dr. Jeffrey Hayes, Education Specialist for the American Society for Reproductive Medicine. Welcome to the latest presentation of the ASRM Grand Rounds webinar series. These webinars are designed to address topics in the ABOG Guide to Learning in Reproductive Endocrinology and Infertility. Today's presentation will be given by Dr. Lubna Paul. Dr. Paul is currently professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences, Interim Section Chief, Division of Reproductive Endocrinology and Infertility, and Director of the Program for Polycystic Ovary Syndrome for the Yale School of Medicine. The title of our talk today is Polycystic Ovary Syndrome, PCOS, in Adolescents. I will now review the details of today's presentation. After the webinar is done, please do not forget to return to ASRM eLearn to take the post-test and complete the survey for your continuing education credits. You must complete the post-test questions successfully and complete the survey to receive credit and be able to print off your certificate. If you wish to ask a question to the speaker about the presentation, when you return to ASRM eLearn, please click on the page link labeled Questions and an email address will be provided. After the time period for questions has expired, the questions page will become a frequently asked questions page pertaining to this presentation and topic. We're very excited for our talk today, so I will now turn things over to our speaker.
Thank you so much, Jeff. Hi, everybody. Good afternoon, good morning. It's my absolute privilege to participate in this ASRM series. And the charge for me is to cover the topic of polycystic ovary syndrome with a focus on presentation and management in the adolescent population. I do not have anything to disclose pertaining to the content or the topic of this discussion. We are just going to move on into my learning objectives. So over the course of the next 40-45 minutes, I'm hoping to convey to the audience of this particular session concepts to allow the audience to appreciate the subtle yet important differences in diagnostic criteria for polycystic ovary syndrome or PCOS in the adolescent population and to contrast these and compare them with criteria that are commonly utilized for diagnosing PCOS in adult women. Hopefully we'll be able to appreciate the metabolic burden and become familiarized with the common management approaches for improving health of the adolescent with polycystic ovary syndrome presentation. And my final and absolute goal is really to convey for you to gain insight into the options that are available for individualized management of PCOS with a specific focus on managing signs and symptoms of bother for the adolescent population presenting with this label of PCOS. So we will start our focus with this case. This 14-year-old obese adolescent brought into the clinic for consultation relating to a recent diagnosis of PCOS. This reflects a common scenario that I encounter on a weekly basis in my clinic. Young girls, frequently accompanied by their moms, recently diagnosed with PCOS, coming with loaded questions about what does it mean for me and where will it lead me and what should I be doing about it. So this 14-year-old, her bother, she comes to us with the complaints of irregular menses every 2 to 3 months. When they do happen, they're heavy, they're painful. She also acknowledges progressive weight gain and is particularly bothered by the symptoms. She also has acne, has been utilizing some topical strategies, acknowledges feeling down, acknowledges that school has become a challenge, and on questioning, acknowledges reports menarche. So period started at age 13. This girl is presenting at age 14 with this spectrum of symptoms. Cursory initial examination identifies that this youngster is indeed obese. BMI is greater than the 95th percentile. She has evidence of facial acne, cystic acne, primarily affecting her face. She comes with some data that were provided. So she had undergone evaluation by her mom's gynecologist and where they had undergone an ultrasound scan utilizing an abdominal approach. And the report stated that she indeed meets criteria for PCOS because she has polycystic appearing ovaries. She also had undergone some metabolic evaluation by her pediatrician and came in with a report that demonstrated dyslipidemia with primarily elevated triglycerides. Her gynecologist had undertaken some endocrine tests, and there was evidence of elevated free testosterone but normal total testosterone. And a metabolic panel also identified a hemoglobin A1C of 5.8%. So the starting question, this 14-year-old coming for consultation for polycystic ovary syndrome, is the question, does she have PCOS? Does this 14-year-old meet criteria for PCOS? And a question for the audience really is it true that she has PCOS, or do you not agree that she does not meet criteria for PCOS? So that launches us into what is PCOS in the adolescent population. Now, I am sure the audience is familiar with the various diagnostic criteria that are floating around for diagnosing somebody with the syndrome, polycystic ovary syndrome. And we started this journey in 1990, where the diagnostic criteria were put together by the NIH and the NICHD. That is still the most robust of the various criteria that are available. And these criteria require, for a diagnosis of polycystic ovary syndrome, presence of hyperandrogenism, either clinical, which is acne and or hirsutism and or thinning of scalp hair, or evidence of biochemical hyperandrogenism, i.e. hyperandrogenemia. And hyperandrogenemia in patients with polycystic ovary syndrome, the commonest manifestation is that of elevated testosterone levels, total testosterone or free testosterone levels. Having said that, 1/3 of women may have evidence of elevated adrenal androgens, the DHEAS. So NIH criteria require presence of hyperandrogenism, either clinical or biochemical, plus presence of an ovulatory dysfunction, which manifests as menstrual dysfunction. So either infrequent irregular menses, oligomenorrhea, or even amenorrhea, which in an adolescent may even present as primary amenorrhea. So no menarche at all. This young kid may present with primary amenorrhea and then be diagnosed with polycystic ovary syndrome. So NIH, again, to underscore, criteria require both ovulatory dysfunction and or menstrual dysfunction and androgen excess, either symptoms or biochemical evidence. 2003, the Rotterdam criteria became widely accepted, first in Europe and then adopted in the United States as well. And while the Rotterdam criteria helped us utilize and throw a big net to catch the PCOS population, it added noise to the population that we did capture. So based on Rotterdam criteria, a diagnosis of PCOS can be arrived at if an individual meets any two of the following criteria: either menstrual irregularity and or evidence of androgen excess, which may be clinical or biochemical, and or classic appearance of ovaries on transvaginal ultrasound, which is called polycystic ovarian morphology. And the polycystic ovarian, I'll touch upon it as we move along, but polycystic ovarian morphology, as defined by the Rotterdam criteria, it utilizes evidence of multiple antral follicles, less than 10 millimeters in size, a number of 12 or more follicles in even one ovary, can identify that ovary as meeting polycystic ovarian morphology criteria, or an ovarian volume of greater than 3 cubic milliliters is also consistent with PCO morphology by Rotterdam criteria. So Rotterdam criteria introduces a heterogeneity in the diagnosis of PCOS. So you can have irregular periods and polycystic appearing ovaries on ultrasound, and you meet criteria for PCOS with no evidence of androgen excess biochemically or no androgen excess symptoms. So Rotterdam criteria utilization allows us to capture a bigger population of women who may be diagnosed with PCOS, but it adds a little bit heterogeneity in the sense that we get very subtle variants of population as well as capture some very normal population who could be labeled as PCOS based on Rotterdam criteria. And most recent criteria were sort of, it was a balancing act. Midway assessment was proposed by the Androgen Excess Society, where the realization was underscored that appearance of ovaries on ultrasound consistent with polycystic ovarian morphology actually reflects an ovulatory dysfunction in a proportion of this population. So Androgen Excess Society criteria identified that in order to be diagnosed with PCOS, you need to have both evidence of androgen excess, which could be clinical or biochemical, as proposed by NICHD-NIH criteria, plus evidence of an ovulatory dysfunction, which may manifest as menstrual dysfunction or which may manifest just as polycystic ovarian morphology. And most importantly, each of these criteria require exclusion of other differential diagnoses which could mimic PCOS, such as hypothyroidism, such as hyperprolactinemia, such as late onset congenital adrenal hyperplasia, such as androgen secreting tumors, such as iatrogenic exposure to exogenous androgens. So after you rule out every other possibility that could mimic the presentation, patient may be diagnosed with PCOS based on any of these three criteria. Now, it is so important to understand that the diagnostic criteria for polycystic ovary syndrome, each one of these that I just discussed, were elucidated and identified and labeled in adult women. These criteria have not been validated in an adolescent population. So diagnosis of polycystic ovary syndrome in an adolescent population has to be really thought through much more critically rather than simplistically slap a label based on criteria which have been validated in the adult population, particularly so the Rotterdam criteria. So as I had mentioned before, so the panel on your right identifies two ovarian ultrasound images. The top one and the bottom one both show multiple small ovarian follicles, which are antral follicles. The top panel identifies follicles that are pushed to the periphery with dense central stroma. This is what is called a pearl necklace sign, again identified in an adult female population. So more than 10 follicles, more than 12 follicles measuring less than 10 millimeters in size, even in a single ovary, in an adult woman, identifies that ovary as meeting criteria for polycystic ovarian morphology, recognizing that this is the sensitivity and the specificity of this diagnostic criterion for adults need to be placed in perspective. Sensitivity for polycystic ovarian morphology, just based on ultrasound appearance alone, is about 75%, with a specificity of 99% in the adult population. Validity of polycystic ovarian morphology based on number of follicles has not been established in a pediatric population, has not been established utilizing abdominal ultrasound imaging technology. Plump ovaries or increased ovarian volume is a more reliable criterion in an adolescent population than the number of follicles. Recognizing young ovaries can have loads of antral follicles just by virtue of having excellent ovarian reserve at a very young age. So number of follicles should not be driving the label of PCOS in an adolescent population. Also important to recognize that in adults, almost 20 to 30% of regularly cycling healthy Paris women, their ovaries may look like polycystic ovaries on ultrasound, may meet the Rotterdam criteria. And this number is even higher, almost to anything from 30 to 50% of adolescents. The ovaries may appear polycystic, may appear to manifest polycystic ovarian morphology as described by the Rotterdam criteria in an adolescent population. So really, the point with this slide, I would like to underscore ovarian morphology should not be used as a diagnostic criterion for diagnosing polycystic ovary syndrome in an adolescent population. In an adolescent population, again, important to appreciate that, again, I'm underscoring the same panel on the left is the polycystic ovary on transvaginal ultrasound identified in an adult woman. On the right side is a multicystic ovary, again ovary is full of tiny follicles with very little stroma that is apparent. The panel on the right, you can see that in young people. You can see that in women with hypothalamic amenorrhea, where the follicles are just stranded at a much earlier stage of development due to dysfunction of the hypothalamo-pituitary signals that would allow these follicles to mature. So again, underscoring that just because a radiologist reads a report that this ovary is multicystic or polycystic does not mean they utilize that piece of the puzzle and label the puzzle as PCOS for an adolescent. Please do not focus on incorporating ovarian morphology in an adolescent as diagnostic criterion for PCOS. Again, I have already mentioned, and this slide is underscoring, that diagnostic criteria based on ovarian appearance in adolescents really do not exist. So let's be cautious interpreting the data that the patient presents to us with. Stepping back, what we know. So does polycystic ovary syndrome exist in an adolescent population? Yes, I do believe there are plenty of data. We're still in the process of learning to try and understand the underpinnings of the entity called polycystic ovary syndrome. And what we do believe for a large proportion of this population, the issues stem probably either in utero, in early pediatric life, in adolescence, and then progress into adulthood. Lots of underpinnings have been hypothesized, very little data to substantiate polycystic ovary syndrome as a genetic disorder. There are snapshots that do seem to suggest that there are multiple genes that may be involved in evolution of the picture of polycystic ovary syndrome, predisposition to polycystic ovary syndrome, but there's no single gene that has panned out as the be-all, end-all for risk of PCOS. So animal models have contributed a lot to our understanding of polycystic ovary syndrome, and it appears to be that in utero exposure to androgens, be it iatrogenic androgens, such as in the animal models, or be it maternal androgens, such as babies of women with polycystic ovary syndrome or babies of women with high androgen levels due to luteoma of pregnancy, for example. So fetal in utero exposure to high androgen seems to set a stage. There are some genetic and epigenetic and a lot of environmental underpinnings that are being hypothesized as of today. Onus is on the research community to really unravel the cause and effect relationships. But maternal obesity, maternal gestational diabetes seem to be contributory to a phenotype of polycystic ovary syndrome in the adolescent population. So important to, if we can optimize maternal health, maternal obesity, better control gestational diabetes, could we impact and reduce the burden of PCOS in the adolescents? That is our hope, but we need data to really prove that by altering maternal health in pregnancy, we should be able to impact on child's well-being. These are hypotheses rather than absolute facts at this point. Baby girls who are small for gestational age tend to exhibit rebound growth, rapid weight gain, and this is the population that is at risk for being overweight to obese in childhood, manifest premature adrenarche, pubarche, and even early onset of puberty. And this is the population that is more at risk from manifesting polycystic ovary syndrome-like features in the adolescent population. More and more focus in the last couple of decades on visceral adiposity, childhood obesity, and its implications, causative implications for a PCOS-like picture in the adolescent population. So what I would really want to underscore with this slide is that there are genetic, epigenetic, environmental influences that are at play that then ring through the rest of that individual's life. And some of these are being recognized as underpinnings to PCOS in the adolescent population. Physiological insulin resistance is the norm. As a child steps into the pubertal growth phase, insulin resistance is a part and parcel of the metabolic milieu of puberty. But if a child in the peripubertal period is already insulin resistant and steps into puberty, the implications of insulin resistance for disturbing the hypothalamo-pituitary gonadal axis, for contributing to the androgen excess both from the adrenal axis as well as from the ovaries, becomes exaggerated. So childhood obesity is being recognized, and concomitant insulin resistance are being recognized as contributory to the mechanisms that underlie polycystic ovary syndrome of adolescents. So whence from and whither to? Whence from, really, we talk about in utero influences, we talk about obesity, we talk about adiposity and insulin resistance as underpinnings. And once this phenotype gets set in, where is this female heading to? She's heading to not just clinical bother related to menstrual irregularity, androgen excess symptomatology, but also potential for subfertility, and even more importantly, metabolic dysfunction that predisposes her for a lifetime exaggerated risk of type 2 diabetes, cardiovascular dysfunction, psychosomatic dysfunction, and overall poor quality of life. And this is the burden that we hope, by addressing the cascade of events early on, we may be able to mitigate. And hence the importance of recognizing polycystic ovary syndrome in the adolescents, because we could intervene and hopefully impact on improving the quality of life of this growing female. So again, this slide underscores the concept which has been sort of proposed very lucidly as a two-hit hypothesis. So there are developmental underpinnings that I already conveyed. The child is born, maybe it's in utero environment, maybe it is intrauterine growth restriction, subsequent catch-up growth, maybe it is environmental underpinnings. Eventually, this child obesity-driven phenotype results in excess androgen production both from the adrenal gland as well as from the ovaries, with insulin resistance playing a major role in revving up the androgen production both by the adrenals as well as the ovaries. Now, once this, in the adolescent period, this phenotype is established of hyperandrogenemia, hyperandrogenism, insulin resistance, it becomes a self-perpetuating cascade. So high androgen milieu and insulin resistant milieu disrupts the function of the hypothalamo-pituitary ovarian axis, alters the pulsatility of the hypothalamic GnRH signaling, leads to a predominant LH-driven environment, disrupts the production, the pulsatile release of FSH, which drives normal follicular development and is responsible for normal ovarian function. So the cascade of high androgens leading to disrupted GnRH signaling, leading to disrupted follicular dynamics, leading to menstrual dysfunction, ovulatory dysfunction, with abnormal ovulatory function, abnormal estradiol and progesterone milieu, contributing to further dysfunction of the GnRH pulsatility, the dominant LH milieu then adding to the insulin resistance drive of high androgen production. So it's really chicken or the egg, we're difficult to tease apart, but once the ball gets rolling, it becomes a vicious cycle of high androgen begetting high androgen, disrupting ovarian follicular dynamics, and contributing to this cascade of events. So, and insulin resistance, contribution of obesity, contribution of lifestyle, contribution of diet, all feeds into this androgen excess. So if we are able to abort this cascade of insulin-driven androgen production early on in life, we may be able to revert this entire cyclic phenomena. And hence the importance of addressing childhood obesity, childhood lifestyle parameters in optimizing reproductive function in female children as well as in male children. So how do we diagnose insulin resistance then? Insulin resistance really is the concept that you are making insulin, unlike type 1 diabetes, where there is dysglycemia due to lack of circulating insulin. Type 2 diabetes or a pre-diabetes is a paradigm where you are making plenty of insulin, and it's just that the signal of the insulin at the level of the receptor is blunted. Clinically, you can diagnose insulin resistance by evidence of central obesity. visceral adiposity and wide waist, high waist to hip circumference, evidence of acanthosis nigricans. So this is a classic description. I have seen many young kids who are brought in for diagnosis of polycystic ovary syndrome, with moms describing that this child at age 7, 8 started to have darkening of flexure creases of the neck, under the armpits, in the groins, and the moms perceived that clinical feature as evidence of hygiene and would spend minutes trying to scrub off these areas. So again, the realization, this darkening of the skin really is at the end organ level a manifestation of insulin resistance. It by no means is reflective of dirt. It is hyperkeratosis driven by high levels of growth factors, including IGF-1 and insulin. Fasting insulin levels are recognized as a hallmark of insulin resistance in the adult population. Young children may not have elevated fasting insulin levels, but when you give them a glucose load, be it meal, be it oral glucose tolerance tests, 75 grams of carb, you land up demonstrating a markedly exaggerated insulin secretory response. So the panel on the right reflects response. So on the x-axis are the minutes following consumption of breakfast, and on the y-axis is plasma insulin levels. And this was a neat randomized controlled trial where these investigators provided adolescent girls and boys, and I'm only showing you data for young girls. They were provided with high glycemic index breakfast items or low glycemic index breakfast items. So high glycemic is presented in red and low is presented in blue, and these are healthy adolescents. And what you see is within 30 minutes of ingestion, there is a marked rise in circulating insulin levels. It is higher when you consume high glycemic index dietary components. Within 60 minutes, these levels start dropping down and then continue to drop down over the course of the next 60 minutes. So in a 2-hour time period, you see the maximum rise in circulating levels of insulin within 30 minutes, and then a gradual decline, recognizing the higher the glucose load and of simple glucose, so glycemic index, the higher the glycemic index, the higher is the rise in circulating insulin levels, even in normal individuals. And interestingly, these investigators showed that insulin response to the same amount of glucose consumption is higher in adolescent girls compared to adolescent boys. So there is a gender disparity in terms of the response. Now, what happens in an insulin-resistant scenario? So these are data really that we have observed in our clinic population. So I have imposed this green line over the graph that I had shown you earlier. So unlike the norm where you have a peak rise within 30 minutes and then a gradual drop off, after 75 grams of glucose consumption in an insulin-resistant population, you continue to see the insulin levels rise beyond the first 30 minutes and may continue to remain high for 3 to 4 hours after a glucose meal or a glucose load. And this population classically can present with postprandial hypoglycemia 3 to 4 hours after a big meal. These individuals, youngsters as well as adults, may complain of either feeling excessive sleepiness 3 to 4 hours after a big meal, jitteriness, or even episodes of anxiety, which can relate to the blood sugar levels dropping down 3 to 4 hours after a big meal due to huge amounts of circulating insulin in their system. So this is really a provoked insulin resistance phenomena that if you were checking fasting insulin levels in the adolescent population to identify whether they are insulin resistant or not, you would completely underdiagnose the phenomenon. So to recap, clinical stigmata should be taken seriously. Evidence of acanthosis nigricans is a hallmark of insulin resistance, and if you were to focus on biochemical evidence of insulin resistance, please consider an oral glucose tolerance test, because fasting insulin does not do justice to the concept of biochemical insulin resistance. So I hope I've been able to convey up till now the pathophysiology of polycystic ovary syndrome, how critical is insulin resistance, and metabolic aspects, and in particularly obesity in driving the processes that underlie the phenomena of polycystic ovary syndrome. I hope I've been able to convey that adult diagnostic criteria must not be applied to the adolescent population when diagnosing polycystic ovary syndrome. Evidence of polycystic ovaries on ultrasound scan must not be applied as a diagnostic criterion for in the adolescent population. I would also like to underscore at this time point that from the onset of menarche, the first 2 years of the reproductive physiology, menses can be normally irregular. So having infrequent, irregular menses within the first 2 years of start of menstrual cycles is not abnormal. Persistence of menstrual irregularity beyond 2 years of menarche should be taken seriously and should be considered. So chronic oligomenorrhea, oligoanovulation beyond the first 2 years of menarche should be given serious consideration as a manifestation, as a possible manifestation of underlying polycystic ovary syndrome in an adolescent population. So moving on then, once we have identified an adolescent who is presenting to us with symptoms, we have been very trigger happy as caregivers in labeling these young people with a diagnosis and have been less vigilant in trying to manage the bother, manage the needs, and manage the risks. So my job as a clinician, whether I'm a primary care provider, whether I am a specialist, my job is not be all and all, is not to diagnose something. My job is to understand, why is this patient coming to me? What is her bother? What are her needs? Because her needs may not jive with her bother. She may be bothered by something completely different from what she really needs. And then I really need to understand what are her risks. So when I identify the management strategies, my goal for management should be to address her bother as well as cater to her needs, and to preempt and intervene to minimize her lifetime risks. So our goal in managing polycystic ovary syndrome in adolescents is not as much in diagnosing PCOS. We should not be trigger happy labeling young people with PCOS, but we should be very vigilant that this presentation may be lasting for a subgroup of the young population. This phenotype may persist as polycystic ovary syndrome of adulthood in as much as 50% of the young girls who are presenting with irregular periods and symptoms or signs of androgen excess. So my management strategy should really be, I want to address her need and her bother for now, but also educate her and her family in terms of the future and preempt and intervene to minimize her risks for the future. So hence the focus on Tailor management approach. Now, if her bother is menstrual dysfunction, I need to focus on strategies that will improve her menstrual function. If her bother is acne, excessive hair growth, or excessive scalp hair thinning, I need to focus on strategies which address menstrual dysfunction as well as androgen excess symptomatology. If her bother is weight gain, I need to utilize all strategies and match those strategies to the underpinnings for that patient. Her bother may be sleep dysfunction, which is so prevalent in young people with metabolic dysfunction as well as young people who carry the label of polycystic ovary syndrome. Depressive symptoms are highly prevalent in women and in young people meeting criteria for polycystic ovary syndrome. Chicken or the egg is difficult to tease apart. Is it the syndrome that contributes to depressive symptoms, or is it a ball of yarn which is very difficult to tease apart, that what is causing what, but they all come together as a complex entity. So chicken or the egg, difficult to tease apart, but when we manage the bother, we can improve the quality of life, mitigate the depressive symptoms without the need for use of a psychotropic agent. So important to recognize that. And our management tailored management should focus on harnessing that patient's risks. She may be presenting to me with acne or hair growth problems, but with her menstrual dysfunction in the setting of obesity, a young person is at risk for endometrial pathology, including endometrial hyperplasia and even endometrial cancer. She may be presenting with cosmetic concerns, but she may be absolutely at risk, lifetime risk for diabetes, short-term risk for diabetes, for metabolic syndrome, which in of itself exacerbates time to event in terms of risk for cardiovascular disease. She may be at risk for deteriorating depression, and a portion of her depressive burden may relate to her perceived concerns about her fertility. It's very common for me to encounter young adolescent population girls who have been diagnosed with PCOS, who at the first consultation verbalize their concerns about their ability to achieve pregnancy whenever they would be ready. So just just providing the label of PCOS to an adolescent, we really, without clarifying the underpinnings, the contributors, and the strategies to optimize their well-being, we are not doing a justice by just labeling a young person as PCOS, because in her mind that adolescent perceive the polycystic ovary is such a misnomer. This adolescent is already burdened by the fact that her ovaries are somehow abnormal, and she's burdened by the fact that her ovaries being abnormal will put her at risk for fertility problems. This young person is not seeking fertility, but is already burdened by those potential for lifetime infertility. So just labeling somebody PCOS in an adolescent population really does add to an individual's burden that we need to be aware of. And we need to clarify the patient's concerns without the patient having had a need to verbalize her concerns. We need to be preempting this. So for our 14-year-old patient, she has bothersome menses every 45 to 60 days. She's bothered by her acne in the setting of elevated free testosterone. She is obese. She has elevated triglycerides and elevated hemoglobin A1C, which identifies her at risk for prediabetes. If this youngster comes from a family with a history of diabetes and premature cardiovascular disease, we've already identified a platform, a playing field where she's racing towards her own risk for these conditions. And she is acknowledging depressive symptoms. So this is our bother. These are her risks we have talked about. So choice for managing issues, let's break them piece by piece. So what are our options for managing menstrual dysfunction? The left panel identifies some very commonly utilized strategies. So combine hormonal contraceptives, which come in the form of pills, or the oral contraceptives, which come in the form of a vaginal formulation, which come in the form of a transdermal formulation of contraceptive strategies that have been commonly utilized in the adult population, as well as in the adolescent population. I have circled here oral contraceptives, which probably are the most commonly utilized hormonal strategy for menstrual regulation in the young population. In girls who have not initiated coitus, who are not using tampons, use of vaginal formulation can be cumbersome, bothersome, concerning, and one always needs to be aware of a possibility that a young person may place something in the vagina which should normally be removed every 3 weeks but is forgotten, and then can contribute to risks of infection, retained foreign body, etc. Transdermal hormonal contraceptive strategy is a convenient formulation, but it is important to appreciate that risk for thromboembolism is documented to be a little bit higher with the use of transdermal contraceptive formulation. And so when considering use of this strategy in somebody who already manifests dysmetabolic features, is a pre-diabetic, features of metabolic syndrome, is obese, this is something that, at least in my personal practice, I would advise against. So oral strategy can be safely utilized in the young population to achieve menstrual regulation. And I will talk about its ancillary benefits for other symptoms in a bit. What other options are available to us for somebody who cannot tolerate a combined hormonal contraceptive strategy? We can use a progesterone-only formulation that to manage menstrual dysfunction. So progesterone-only pill can be prescribed. Progesterone can be used cyclically. Again, is available both oral, intramuscular, subcutaneous, vaginal, as well. Progesterone-only option as an intrauterine device has been utilized in the adolescent population to confer endometrial protection and to improve menstrual burden with tremendous success. Plenty of emerging data have substantiated that a progesterone releasing intrauterine system is well tolerated by adolescent uteri, offers menstrual regulation, offers menstrual protection, as well as reliable contraception. On the right panel are a few other strategies under miscellaneous. Metformin is an insulin sensitizing agent commonly utilized for management of metabolic burden of polycystic ovary syndrome. Interestingly, a large body of data, primarily in the pediatric world, identifies safety of metformin, efficacy of metformin, and benefits of metformin as first-line approach in the adolescent PCOS population. So metformin use, given 3 to 6 months, can improve menstrual cyclicity in as much as 30 to 50% of the population, also offers benefit against some androgen excess symptoms, offers benefit against metabolic features that I'll touch upon. I'm not going to talk too much about glucocorticoids or GnRH agonists as strategies which have been tried in the adolescent population, still have a role in a subgroup of patients. So when adrenal androgens predominate the clinical picture, and once you have ruled out late onset congenital adrenal hyperplasia, but DHEAS appears to be the dominant elevated androgen in an adolescent who is bothered by menstrual issues, who is bothered by androgen excess issues, and nothing else works, or she cannot tolerate contraceptive hormonal strategies, does not wish to utilize progesterone-only strategy because progesterone only offers benefit for uterine bleeding, but not for androgen excess symptoms. Low-dose glucocorticoids can offer benefit, and in some patients, GnRH agonists, by lowering the LH-driven androgen excess, can offer some benefit. So these are really strategies that should be utilized by subspecialists if nothing else is available to the patient. Some data, mostly in the adult population, that myoinositol or vitamin D may improve insulin signaling at the level of ovarian tissue and may improve menstrual cyclicity. Again, mostly adult data vary, but these are agents that are safe, that are well tolerated, and we need data in the adolescent population before we can go and recommend utilization of these agents. Lifestyle modification must be identified and utilized as the first-line approach for managing PCOS in adolescents as well as in adult women. Lifestyle should take into consideration physical activity, dietary profile, dietary modification, weight reduction, and stress reduction. Recognizing a state of chronic stress itself feeds into mechanisms that underlie insulin resistance. So upregulated cortisol profile feeds into the state of insulin resistance. So lack of sleep, chronic depression, worsening stress itself is fuel for insulin resistance. Having talked about managing menstrual regulation, what strategies we have, let's now focus on if the predominant bother is from androgen excess, what are our options available for the adolescent population? So combined hormonal contraceptives that we just talked about as a strategy for managing menstrual irregularity have an adjunct and a dominant benefit against symptoms of androgen excess. So a couple of ways whereby a combined hormonal contraceptive actually benefits symptoms of androgen excess is through the estrogen component of a hormonal combined hormonal contraceptive actually bumping up the circulating sex hormone binding globulin levels. Sex hormone binding globulin is produced by the liver. It's a binding protein that gets upregulated by estrogen. Higher the dose of estrogen, the higher the magnitude of rise of sex hormone binding globulin through the use of orally administered estrogen. Sex hormone binding globulin, when goes up, it binds the circulating androgen and it brings down the free androgen excess. So recognize that in our index case, her total testosterone is normal, but her free testosterone is elevated. So when you bump up the sex hormone binding globulin through use of an oral estrogen, you will lower and even normalize the free androgen index, free testosterone levels in this patient. The progestin of the combined hormonal contraceptive has dual benefits. Number one, progestins actually suppress the LH release by the pituitary. So the progestin component, by lowering the LH release, actually lowers the LH-driven testosterone production by the ovarian theca as well as by the adrenal gland. So dialing down of LH through effective progestin of a combination contraceptive brings about reduction in total testosterone levels. Secondly, certain types of that progestins, drospirenone is the progestin which is available in the US, which has direct anti-androgenic properties. So it acts like spironolactone by having a potential to block the androgen signaling at the level of the androgen receptor. So combined hormonal contraceptive through its estrogen component and through its progestin component reduces the circulating free androgens through direct effects at the level of the pituitary by lowering the LH and thereby LH-driven androgen, and by effects at the level of bumping up the sex hormone binding globulin, both of these effects lowering circulating androgens. And if you chose the drospirenone containing contraceptive pill, you also block the androgen receptor signaling, and thereby the end result is reducing symptoms of androgen excess. Recognizing that effects at the level of the skin, the pilosebaceous unit. So acne responds much quicker to these strategies than hirsutism. Hair follicle has about a 6-month cycle of growth. So benefit against hair growth, it would take almost 6 months for us to see mitigation in hair growth. So the thickness of the hair shaft becomes a little bit less, frequency of growth of hair becomes a little bit dampened. It can take up to 6 months, whereas benefits against acne are apparent much sooner. So combination hormonal contraceptive in an adolescent population is a great strategy to address symptoms of androgen excess. Choice of the progestin in the pill, so head-to-head comparisons, mostly in the adult population, have identified that drospirenone containing oral contraceptive pills work better than non-drospirenone containing oral contraceptives in terms of reducing the symptoms of androgen excess. Again, underscoring that head-to-head comparison data are not available for the adolescent population, but can be extrapolated from data that are available in the young adult population. So we have our option of a combined hormonal contraceptive, as I just discussed. We have options of just using an anti-androgen, such as spironolactone, or another anti-androgen, something called finasteride. So unlike spironolactone, where the predominant effect is at the level of competitive blocker of the androgen receptor, finasteride dials down the enzyme activity for 5-alpha reductase, which is the enzyme that converts testosterone to a much more potent form of testosterone called dihydrotestosterone at the level of the target organs, such as the skin. So both spironolactone and finasteride have been utilized in management of symptoms of androgen excess primarily in the adult PCOS population. Data in the adolescent population are sparse, are observational, but are reassuring. Very important to understand. So these two agents do work in terms of benefiting the symptoms of androgen excess. Spironolactone use itself in the adult population has been tied in to improving menstrual cyclicity in of itself. However, it is so important to appreciate that anti-androgens are potentially teratogenic. So what they're doing is spironolactone is primarily blocking the androgen receptor signaling. Spironolactone has a very mild 5-alpha reductase activity as well. Finasteride is primarily 5-alpha reductase inhibitor, blocks the production of dihydrotestosterone. Both these androgens are vital or critical to the development of external genitalia in the setting of an early conception in a male fetus. So if a woman using these anti-androgens inadvertently achieves a pregnancy, there is potential for teratogenicity with these agents. So utilizing these agents in an adolescent population, one needs to realize how important it is to have concomitant contraception for adolescents who are sexually active or who may become sexually active over the course of the next few days, months, years. Flutamide is an anti-androgen that has really, its use, at least in the United States, has dwindled because of documented hepatotoxicity, and I'm not going to talk about that. So really, the panel on the left is the combined hormonal contraceptive regimens as well as use of anti-androgens, absolutely validated in the adult PCOS population. Combined hormone contraceptives with the use of an anti-androgenic progestin such as drospirenone have been validated in the adolescent population with PCOS. Spironolactone and finasteride, sparse data in the adolescent population, but efficacy well established in the adult population. If being considered for the adolescents, one must take into consideration need for reliable contraception, given the potential for teratogenicity. Now let's switch to the panel on the right. If one was to peruse the literature on strategies used for managing androgen excess symptoms in adolescent PCOS populations, metformin dominates the agents that have been utilized. So while combined hormonal contraceptives are commonly utilized by gynecologists seeing adolescent patients with PCOS symptoms, metformin is preferentially utilized by pediatricians and pediatric endocrinologists as first-line strategy for managing PCOS-like symptoms in adolescent population. Some encouraging data that when you combine metformin with a combined hormonal contraceptive, you may actually get enhanced benefit than use of single agent alone. And combined hormonal contraceptives have been also utilized with the anti-androgen, providing contraceptive efficacy, providing all the benefits that I've already talked about in terms of lowering the free androgens, and then in combination with an anti-androgen such as spironolactone or finasteride, some added benefit for symptoms of androgen excess. This last strategy of combination hormonal contraceptive and anti-androgen has mostly been documented in the adult population, but is extrapolated to be of potential benefit for the adolescents, provided it is underscored that reliability of contraceptive use is of supreme importance in this setting. What other agents are available? So ornithine decarboxylase inhibitor is a topical agent. It essentially blocks an enzyme that is involved in cell proliferation, and bulk of data with Vaniqua use in improving excess hair growth is available for the adult population. Almost 50% benefit against hirsutism only while it is being used. Takes about 6 months to make a difference. Works while you're using it, you stop using it, and the benefit goes away. Downside is ornithine decarboxylase inhibitor. Most of the insurance companies do not cover this. So it becomes an expensive strategy out of pocket, which only works while you're applying it. So benefit for the adolescent population still needs to be proven. Again, I touched upon glucocorticoids earlier. I'm not going to belabor this concept other than stating that low-dose glucocorticoids dial down the production of adrenal androgens. So if adrenal androgens are the predominant source of androgen excess, low-dose glucocorticoids may have a role in the hands of specialists. Some data in adults as well as adolescents about statins dialing down the production of androgens both by the ovaries as well as the adrenal glands. But statins, there's potential for teratogenicity. So when statins are being used as a lipid-lowering strategy in an adolescent population, need for contraception should be underscored. GnRH analogs, by dialing down the pituitary LH, can impact on androgen excess symptoms. In very rare scenarios, has this strategy been utilized as a first-line agent for managing ovarian androgen excess. Again, myo-inositol and vitamin D in adult population have been shown to reduce circulating androgen levels. In the adult population, their potential for benefit in adolescents has yet to be proven. So when choice of combined oral contraceptives, I already talked about how the estrogen component is important in terms of bumping up sex hormone binding globulin and thereby reducing the free androgen levels. I also talked about the progestin component, that anti-androgenic progestins have an added efficacy, but any progestin also has some efficacy by lowering the LH production by the pituitary gland. I'm now going to present you yet another concept, which really is that ballpark, the synthetic, the progestins, have been classified into 3 different categories of androgenicity, depending on the structure of the progestin molecule. These are testosterone derivative progestins, and some of them are androgenic in their action. While they're great progestins at the level of the endometrium, they may actually act via the androgen receptor because of the structural similarity with testosterone. So when you're choosing a combination contraceptive pill, you should take into consideration not just how much estrogen is in the pill, but also what progestin should I be using for managing symptoms of androgen excess in a young person. So in this, the colors that have been used are really of a traffic light. So the red is caution, stop. So levonorgestrel, norgestrel, these are highly androgenic potency progestins. They're great progestins, but they act like testosterone at the level of the androgen receptor and can actually exacerbate acne in somebody with evidence of, with symptom of acne. The yellow are midway, medium androgenicity, whereas the greens are the preferential progestins that should be considered when deciding on an oral contraceptive formulation for use by a woman who or an adolescent who has symptoms of androgen excess. So really putting into consideration some thought needs to go in terms of which pill should I pick up? Why should I pick up this pill? So if I'm worried about sort of risk related to estrogen component of the pills, for example, when I'm choosing pills in an older woman, when I'm choosing pills in a young person who starts experiencing nausea with a higher estrogen formulation, or breast tenderness with a higher estrogen formulation, or psychological issues like emotional lability with a high estrogen, I want to choose the low estrogen component pill. But I don't want to go very, very low because I really want to bump up the sex hormone binding globulin, which is the effective estrogen component of the pill. So I choose a lower dose estrogen, but then I want to choose a progestin in that estrogen category, which is of least androgenic potential. So my personal preference when I am prescribing or choosing an agent for use by an adolescent who has symptoms of androgen excess or evidence of androgen excess, I preferentially choose drospirenone-containing oral contraceptive or a low androgenic potency progestin such as norgestimate. When I am choosing a oral contraceptive for managing dysfunctional uterine bleeding in a woman without any concerns for androgenic potency, I may choose to use high androgenicity progestin that is also a strong progestin at the level of the endometrium. So really the choice of pills in an adolescent with PCOS take into account what estrogen dose should I be using and why am I choosing that dose? Why am I avoiding higher dosages for that patient? And secondly, the progestin that I choose should be of low androgenic potential because I do not want to exacerbate her already existing bothersome symptoms. So become familiar with few categories of progestin across a few categories of estrogen dosages, and then you'll have your own battery to choose from. So back to our 14-year-old patient, from a gynecological perspective, I would prioritize nutritional counseling as a critical element to her management because this young 14-year-old is obese, is dyslipidemic, meets criteria for metabolic syndrome. Her big bother is continuing weight gain. I've not presented you the data, but if you start questioning, chances are that there is a sedentary lifestyle, poor dietary choices. So nutritional counseling is absolutely critical. Metformin should be considered as a first-line approach in this individual who is obese, who is dysmetabolic. She has manifestation of depressive symptoms. I already touched upon how depression feeds into the insulin resistance cascade. One would strongly advise seeking psychological support. Her issues are menstrual irregularity with painful prolonged bleeding and symptoms of androgen excess in the setting of elevated free testosterone. So in the absence of premature cardiovascular disease in the family or thromboembolic phenomena, a drospirenone-containing combined oral contraceptive may be an appropriate first-line strategy, could be used alone or in combination with metformin as a dual strategy. Now, this is an ideal patient to consider a combination of levonorgestrel intrauterine system that would address the endometrial concern, that will address the heavy prolonged bleeding, and combine the levonorgestrel intrauterine system with an anti-androgen. Recognize levonorgestrel is a potent it's a potent progestin of androgenic potency. So if you're going to use this in somebody who already has symptoms of androgen excess, you should complement it with an anti-androgen. So levonorgestrel IUS plus spironolactone is increasingly being utilized in my clinical practice, in my colleagues' clinical practice, as a way to address symptoms of androgen excess and bothersome menstrual concerns in an individual who is deemed at lifetime risk for endometrial pathologies. Risks versus benefits of combined oral contraceptives in adolescent population. So this is really a review. Benefits are you offer menstrual regulation, you improve dysmenorrhea in this population, you offer strategy. This is a strategy to improve symptoms of androgen excess. Acne gets improved, hair excess, hair growth also gets some improvement, which is a little bit delayed. Acne benefits are seen much earlier than benefits against hair growth. Yet another metabolic benefit, if you will, of oral combined hormonal contraceptive is that the estrogen component does bump up, along with many binding proteins, also bumps up the HDL, hepatic production of HDL, and offers some metabolic benefit. Having said that, the estrogen component of the pill also bumps up triglycerides. So really, you don't use a combination contraceptive for its metabolic benefits. You use it for its benefits against endometrial risk as well as for symptoms of androgen excess. We must keep in perspective that use of combined hormonal contraceptives, oral contraceptives, transdermal contraceptives, vaginal contraceptives in the adolescents may be associated with some bother, and the bother may be psychological. So some adolescents, again, this is a population where dysthymia is more prevalent, depressive symptoms are more prevalent, and for some of these young people, depressive symptoms may actually exacerbate, particularly with the use of cyclic regimens of contraceptives, and this population may do better with a continuous or a long cycle hormonal formulation. In an adolescent, use of oral contraceptive, compliance with daily pill taking needs to be evaluated and these patients need to be counseled about the importance of compliance, because breakthrough bleeding is actually commonly seen in the setting of missed pills. Metabolic, I already touched upon, that worsening of triglycerides may be seen. So this patient of ours who already has some elevated triglycerides, giving her an estrogen-based contraceptive formulation, you may see a deterioration in triglycerides. So it behooves us to monitor the lipid profile when we choose to initiate somebody with existing dyslipidemia with a combined hormonal contraceptive strategy. Some data about worsening insulin resistance. Again, this is, as well as elevated CRP, inflammatory biomarkers in users of oral estrogens, have been described, but in short term, these really are more of surrogates rather than absolute risks. So I would not use an oral contraceptive in a young person because of worsening insulin resistance, but that's a population where I would choose to maybe consider combining metformin with combined hormonal contraceptive formulation. Risk of gallstones in OCP users is real, and that again needs to be placed in perspective, particularly when you are dealing with somebody who already has dyslipidemia. Again, clinical evaluation history taking is so critical, and if you have any concerns, getting a right upper quadrant ultrasound to make sure we're not missing any existing gallstones, or we may exacerbate risk for a person who's already at risk for cholecystitis or even pancreatitis related to gallstones. Some interesting data, sparse data, but meaningful data nonetheless, that use of combined hormonal contraceptives in the adolescent population may for some attenuate the peak bone gain that is the norm in the adolescent population. So we should be really vigilant in counseling patients about use of combined hormonal contraceptives in the adolescent age group. So an adolescent who comes from a family where there's a strong history of osteoporosis, where the adolescent has a personal history of eating disorder, maybe meeting criteria or presenting as a PCOS-like picture, I may choose to give cyclic progesterone or a levonorgestrel intrauterine system and an anti-androgen to address symptoms of androgen excess, rather than to initiate her management with a combined hormonal contraceptive as a first-line approach. So again, skeletal health should be considered and management individualized. Peak bone gain may be affected in OCP users for some adolescent population. Risks versus benefits of an anti-androgen in the adolescent population. Again, I've already breezed through this, but to recap, improved symptoms of androgen excess, hirsutism, acne, hair loss, recognizing hair-related symptoms, there may be a lag of even up to 6 months. A proportion of anti-androgen, a proportion of adolescents using anti-androgens may even experience improved menstrual regulation, particularly if high androgens are feeding back into disruption of GnRH signaling. So when menstrual regulation happens, and if that adolescent is sexually active and not using contraceptives, she is likely to she's at risk for unplanned pregnancy. So always underscore use of an reliable contraception when you're prescribing an anti-androgen to anybody, to a reproductive age woman, to an adolescent as well as an adult woman. Some metabolic benefit, improved lipid profile, has been described mostly in an adult population with the use of anti-androgens. Again, you don't choose anti-androgens for metabolic benefits for adolescents. You really use this particular class of agents to address symptoms of androgen excess. The back of your mind, flutamide I already mentioned should not be used. Risk of hepatotoxicity is higher than with spironolactone or with finasteride. I have already mentioned about risk for teratogenicity. Cannot underscore enough times that if you are considering use of an anti-androgen in an adolescent population, reliable contraception must be underscored, and that's where a levonorgestrel intrauterine contraceptive system gives the best of both worlds in terms of reliable contraception that could be complemented and teamed with an anti-androgen. So up till now, I've walked you through predominant gynecology perspective, including my own perspective with how would I deal with this patient. Now, let's talk a little bit about, and I've already conveyed to you that the pediatric literature really prioritizes metformin as a first-line strategy. And for a 14-year-old who is obese, who is dysmetabolic, really metformin should be considered as a first-line approach, either alone or in combination with a hormonal contraceptive strategy. So pediatric perspective underscores many hyperandrogenic girls receive standard therapy with an estrogen progestin through adolescent and early adulthood, despite perplexing absence of reassuring evidence on potential effects of this long-term treatment of features such as adiposity. So this particular Ibanez et al., this group has published large body of data on the adolescent population, the burden, metabolic burden in the population, and benefits of metformin in this population. So, and they rightly point out that long-term data in terms of safety of just oral contraceptive use for the sake of managing symptoms of PCOS, they're lacking. we have been very trigger happy with prescribing an OCP for menstrual regulation and conveying to the adolescent and to the family that this is the treatment of PCOS. But now it's time that we step back and we parse out, we match the tool that we pick to the issues that are apparent in the patient. So for this particular patient, really, from a pediatric perspective, even nutritional counseling is critical. Metformin is the first-line approach. And from a pediatric perspective, not just for obese, but also for the lean population. And here's a reference that I would encourage you to review. So metformin, the mechanism of action of metformin in the setting of an adolescent PCOS with evidence of insulin resistance, with evidence of androgen excess, is metformin acts by targeting both insulin resistance, improving insulin signaling, and lowering circulating levels of insulin. And it also seems to have a direct effect at the level of the ovary, downstream signaling beyond the insulin receptor. It brings about improved steroidogenic profile and lowers production of androgens by the ovarian theca. Some data, very reassuring data in the pediatric population, that in that obese young child manifesting symptoms of pre-adolescence. So we are now talking pediatrics. So a young child manifesting signs of precocious pubarchy. These are kids who are at risk for precocious puberty. With precocious puberty comes hand in hand risk for stunted adult height, because as well as for evolution into polycystic ovary syndrome. The PCOS phenotype, PCOS, endocrinology is much more prevalent in girls who present with precocious pubarchy, adrenarche, as well as precocious puberty. So this panel on the left presents data where girls with evidence of pubarchy were initiated on a metformin and versus left untreated. And this is time to event, and the event under consideration is the onset of menarche. And what you can see in metformin users, onset of menarche is delayed as much by almost 2 years compared to untreated girls, recognizing both these populations manifested evidence of pubarchy. So use of metformin in the at-risk population in young kids who have evidence of early activation of the adrenergic axis may be destined to early menarche, may be destined to evolve into a PCOS-like picture. Initiating metformin, continuing metformin for a few years may actually benefit them in terms of delaying menarche. And by delaying menarche, what you eventually achieve is so the peak the peak height that the child would achieve could be maximized by delaying menarche. So the data on the right for the same population, these girls were started on metformin versus no treatment. Starting age was 8, and they were followed till post-menarche to age 13. And the estimated height at the time of age 8 years, the distance to target height based on mid-parental height was 32.6 centimeters plus minus 1.3 for the population, and the same for the metformin-treated population. But after post-menarche, the untreated population was almost 5 centimeters short of their estimated height. So they had a shorter height compared to the girls who were treated with metformin, who were taller than the girls who remained untreated with metformin. So really what this study underscores is metformin is a safe strategy, and it, for patients who are manifesting signs of early activation of pubarchy and adrenergic axis, who are at risk for early onset puberty, at risk for early onset menarche, you may, through use of metformin, not only prolong time to onset of menarche. Remember, early menarche in of itself has a huge burden on the child, on the family. So there is psychological distress related to precocious puberty, to early onset menarche. There's social impact that on the family and on the society from early onset menarche, and there's lifelong psychological burden on a child who steps into reproductive life prematurely. So metformin use can really mitigate these long-term detriments on kids who are appropriately selected for its use. So risks versus benefits of metformin in the adolescent population. Benefits then are metabolic benefits. Reduced cravings for carbs. So this is so commonly acknowledged by the parent, not as much by the child, of the youngster having binges on carbs. And metabolic benefit of metformin includes reduced cravings for carbohydrates, reduced weight gain, and actually facilitating weight loss, improved lipid profile, improved glycemic profile, lower circulating insulin levels, and actually improved inflammatory milieu. Almost 50% of patients using metformin from 3 to 6 months down the road may experience improved menstrual regulation, almost 11% reduction in circulating androgens, as well as some improvement in acne. Hair growth per se has not been shown to improve with metformin use alone. I've already talked about benefits in terms of delaying age at menarche, as well as eventual height gain for girls who are manifesting signs of adrenarche prematurely. Risks, it's a fairly safe strategy, metformin. Gastrointestinal disturbances are described almost by 20 to 30% of the population, but they can be minimized through use of starting with a very low dose with a meal and gradually escalating the dose up to as much as 850 milligrams a day to 1500 milligrams a day of metformin for the lean population, and up to 2000 milligrams a day for the obese population. Vitamin B12 absorption can be affected in patients who are using metformin long term, and supplementation is recommended. Lactic acidosis is a rare event. Patients with renal dysfunction, metformin really should not, in youngsters and adolescents where kidney function is compromised or there is concern, metformin for management of polycystic ovary syndrome related symptoms should not be considered in this population. My personal preference is to get a renal panel, a metabolic panel, including serum creatinine, before I initiate metformin in anybody, whether it's an adult or an adolescent. So the take-home message for diagnosing PCOS in adolescents: is there a need to diagnose? Absolutely, yes. PCOS diagnosis has long-term health implications, as I have talked about. There are metabolic implications, there are reproductive implications, there are psychological implications, there are cardiovascular implications. However, not everybody who looks like PCOS based on diagnostic criteria for adults actually has PCOS in the adolescent population. So you really need to choose the right tools. My personal preference and my message is, let's not be hasty in labeling somebody with PCOS in the adolescent time period, but let's be very vigilant about manifestations of PCOS-like symptoms so we can harness them. Let's follow these adolescents into adulthood, or at least 2 years beyond menarche, to make sure that the menstrual irregularity that I'm using as a diagnostic criterion is not the transient menstrual irregularity that is normal for an adolescent, but it's persistent. So if it is persistent, if there is persistent hyperandrogenism or hyperandrogenemia, I feel comfortable in diagnosing a young person as meeting criteria for PCOS. I'm very reluctant to use ovarian morphology as a diagnostic criterion, and I hope I've been able to convey to you that there are no existing data about how many antral follicles in an adolescent ovary are too many for a normal adolescent. So let's not use Rotterdam criteria for diagnosing PCOS in an adolescent population, and let's focus not on delivering the label of PCOS, but to individualizing and addressing the bother and management risks through individualized management strategies. A liberal dose of lifestyle, judicious use of hormones, and prioritizing metabolic management, recognizing that insulin resistance is pivotal to the entire cascade of events. So how to diagnose then? An adolescent should not be diagnosed with the syndrome based on polycystic ovarian morphology on ultrasound. Chronic hyperandrogenemia and menstrual dysfunction persisting beyond 2 years of menarche are required for diagnosing PCOS in adolescents. Recognizing for many hyperandrogenemia may not be complemented with hyperandrogenism, and for many hyperandrogenism may occur in the setting of normal androgen circulating levels. We also need to appreciate acne in adolescents is a physiological phenomenon. So we really need to understand, to pay some attention to what kind of acne, how much of a burden of acne do I consider as a diagnostic criterion for labeling an adolescent with PCOS. So clearly cystic acne, acne not just on the face but on upper shoulders, back, butt area, so areas which are rich in pilosebaceous glands, that kind of that distribution of acne is more manifestation of hyperandrogenism than just a few spots of facial acne, which are so common in an adolescent population. So I hope we've been able to appreciate the subtle yet important differences in the criteria for diagnosing PCOS in adolescent girls compared to adult women. I hope that after hearing, the audience would be able to appreciate the metabolic burden and have now become familiarized with the common management approaches to improving health in an adolescent who meets criteria for polycystic ovary syndrome. And I hope that we are now familiar with options that are available to us for individualizing management of PCOS-related signs and symptoms in the adolescent population. And here are some of the references for your benefit. Again, it's been my privilege to be a part of this series, and I look forward to questions. Thank you.